Good afternoon, everyone. Welcome to GSI Health Series on Population Health Management. Today's topic for November 16, 2016 is Beyond Traditional Case Management, the integration of population health management into post-acute care. Our speaker will be Lee Jones, Chief Executive Officer and founder of GSI Health. At this moment in time, you are all being muted as attendees in the webinar. However, you can enter questions to the right using the navigational pane from the GoToWebinar link as shown on the screen here. At the end of our session, we'll review certain questions and have a discussion of those topics with our presenter, Lee Jones, today. If you have any questions during the broadcast that impact things related to audio quality, etc., please use the chat window also in the GoToWebinar link. At the end of our session, we'll send a link to all of you in early December for a recording of this webinar to share with your colleagues. In terms of today's session, our speaker is Lee Jones. He's the Chief Executive Officer of GSI Health, a healthcare technology and solutions company that provides integrated care coordination and analytics enabling the whole person care, specifically for complex populations. GSI Health is on the forefront of population health management solutions for broader value-based care arrangements and has helped pioneer working models for effective collaboration in community-based care delivery. Mr. Jones is a recognized speaker in healthcare information exchange and health IT more broadly, performing strategy development and business analysis, technical architecture, and solution design for a range of public and private endeavors. He's assisted several states in the development of architectures and operational models for health information exchange, including the ability to transact critical information across the healthcare continuum. Mr. Jones holds a Master of Science in Engineering in the Management of Technology jointly from the Wharton School and the School of Engineering and Applied Sciences at the University of Pennsylvania, and a Bachelor of Science in Computer Science from Carnegie Mellon University. There's some additional information to your right about Mr. Jones's various leadership of industry initiatives related to health information technology exchange. And throughout the course of our series and today's specific discussion, Mr. Jones will highlight his perspective on how we can support value-based care in the evolving healthcare landscape. So at this time, I'll turn it over to our speaker today, Lee Jones from GSI Health.
Thanks very much, Sean, and good afternoon to all of you who are on the line. We really appreciate you joining us for this webinar. As was stated, this is a series that we've been conducting, and our intention in doing these series is really to help to move the entire industry forward by contributing our small part in giving everyone the benefit of our experiences. We've had a number of these webinars in recent months, and they've been focused on a number of different value-based care initiatives. We sometimes had guest speakers as well as our staff presenting. We've talked about bundled payments, and we've talked about DSRIP and health homes and other such activities. Today's talk is a little bit different in as much as with all of these different value-based care initiatives, there's one common factor that we see all the time, and that is the hospital. And the hospital tends to have different roles in these different kinds of arrangements. And so we wanted to talk a little bit about the hospitals, and in particular, this idea of case management, which is certainly something that's very common in the hospital setting, and how it relates to population health and care management. So I'll be talking first about what I'm calling the population health mandate, and then look a little bit at some of the approaches that hospitals and others who are involved in these value-based care initiatives can take. And so those will be our topics, and as was stated, we'll have some time at the end to answer any questions that you may have. I always like to start these talks by giving you a sense of our context so you understand where our viewpoint comes from. GSI Health provides a platform in the form of software as a solution that supports value-based care initiatives and population health management. We have two big categories of functionality. One I'll call care coordination and care management, which allows our users to manage populations and behave as a team as they jointly care for patients individually as well as the population as a whole. And then there is an analytics portion which allows them to analyze the care that's being delivered and to also do a number of necessary steps like stratifying patient populations so you can vector your time appropriately, etc. So our discussion today and all of our discussions really builds upon the experiences that we've had with our customers who are trying to do these kinds of programs. And so we are really reflecting things that we see as well as some of the things that we hear and experience as we go around the industry and talk with people likely like you. And so that's sort of where our perspective comes from. That being said, let's jump into this idea of the population health mandate. And so to this crowd especially, I'm sure it's no surprise that population health remains a very hot topic. It's been sort of at the top of the hype cycle for a long time now, but it persists because there's still a strong support from the payer community, the public payers and the private payers, to move toward value-based care and to encourage the use of population health management approaches in the satisfying of those. These are some headlines. There are even more recent headlines that weren't included. And I think that the stated intention of many payers is to move toward risk-based contracts and arrangements with providers so that providers are able to shoulder some of the risk and use it as an impetus to have them manage more effectively when it comes to their patient populations. And with that sharing of risk, then also is a sharing of reward, and there are various stages that a number of programs have implemented en route to that risk. So I think that one thing to note is this shifting of risk to providers beyond where it had been before inherently brings about the need for a more intensive kind of management, the management that would enable them to optimize their risk position and to maximize any returns and gains that might come out of such a relationship. And so we've seen over the recent years a proliferation of different kinds of models and different experiments, as well as serious programs that have come on board, and more patients in Medicaid and Medicare and other circles are being put into these value-based arrangements, and so it's getting a little crowded. Not only are there starting to be overlapping patients, but organizations and networks that have formed to take on these kinds of arrangements are starting to have overlap in their operations as well as their patient populations. And one thing that seems to be fairly common and standard is the participation of hospitals in these networks, because hospitals really represent something special when it comes to this idea of collaborative care. And so hospitals are interesting because they can find themselves in any position, either squarely within any of these programs or sitting outside of them, leading them, or being recruited to just be a participant. In all of these different roles, the hospital is seen as a key player and an anchor tenant. And so this role of the hospital is really a focus that we want to talk about today, and in particular, in as much as hospitals have been doing a kind of care coordination in case management for a number of years, we want to see how they can transition from that kind of a model into this population health model, and to see if there is actually a real difference to be had here. So the takeaway here is hospitals will be impacted by this movement if they have not all been already, and so they should have their own delivery model with respect to population health management activities and understand how they're going to set their own course and be the master of their own destinies as these programs pop up or as they decide to have them. So I want to pause here and ask a couple of questions on the poll. So I'm going to put forward a poll, and you'll see it on your screen, and I ask that you would respond to the question. And so the first question I'm going to ask is your organization involved with any value-based care initiatives that involve population health management approaches? So I want to get a sense of who's in the audience, and then I'll share those results with you. And so you should see on your screen now the actual poll, and if you would take a moment to respond to that, we'll just give you a few seconds to do it. People are still voting, so I'm still paused. It looks like it's slowing down. All right, I'm going to close the poll in 5, 4, 3, 2, 1. And so you can see on the screen how the answers came. It looks like 38% of you have are sponsoring a value-based care program, and it looks like there's a pretty even split between people who are doing multiple of those programs as well as not participating at all. And so there's a diverse population here, but I think it helps you to know who else is watching with you, and it helps us to also understand the landscape. I do want to ask another question at this point, just before we move into the next topic. And that question is, does your organization make a distinction between case management and population health management, for those of you who are involved in those kinds of activities? So I'm going to launch that question, and after we answer this question, we'll move forward in the presentation. The votes are still coming in. Looks like it's starting to slow down. And so I'll close this poll in 5, 4, 3, 2, 1. And so as you can see, you know, just under 80% of you say that there is a distinction that your organization makes, and just over 20% says there's no distinction. So that was part of the challenge in trying to speak to this topic today, because there's different nomenclature and definitions. People call case managers and care managers sometimes with definite differences, sometimes with no distinction between them. And so what you'll see in these subsequent slides are how I'm framing these definitions, so just so you have an understanding of what I mean when I use these words. So thank you for participating in the polls, and we'll continue on with the presentation now. So population health management really undergirds value-based care, and this definition coming from Chilmark for population health management I think is a useful one. The proactive management of health of a given population by a defined network of financially linked providers in partnership with community stakeholders such as social workers, visiting nurses, hospice, patient caregivers, family, etc. And there are really 3 key points that Chilmark points out, and I tend to agree with. It's a move from being passive to proactive. And by that, we mean in a number of case management models, people deal with the patients that are coming in and having encounters in the hospital. And so the patients are coming to them, and then they are engaged and entered into a caseload. And that is more of a passive approach. You're not actively seeking out the patients and trying to bring them in. Whereas in population health management, the emphasis is really trying to understand the population and proactively manage them even prior to their encounters. Second of the key points here is that there's a defined financially linked network, and that's important because it's one thing to have generalized networks such as referral networks where there may be various kinds of arrangements and understandings between organizations, but when there's a financial incentive and financial relationship between the parties, it helps them to put forth their best efforts and be accountable to one another. And so that's a key factor in population health management success. And then there's collaboration with the community network. So everyone now realizes that there are a number of factors that contribute to one's health. Medical factors are certainly one, but there are also behavioral health and socioeconomic factors. And so taking into account the entire patient is becoming a best practice and one that's espoused by many. So with this kind of charge that's given to the industry around population health, and all of the hype and all of the programs and all of the different ways to participate, it seems as though there are varying manners that organizations sort of take this up. And it reminded me of playing Monopoly. So I don't know about you, but when I used to play Monopoly as a kid, there were always people who had different strategies, but there were always two strategies that always stood out to me. First strategy was the person who just burns around the board and starts buying up everything, going almost broke, trying to buy up every property that they land on before they get to go, and then keeping that going in an attempt to sort of do a land grab and get people to start paying them as soon as possible. We see a similar, or saw a similar thing with population health management efforts when there was lots of grant money and experimentation money. People were just doing lots of things, buying things, trying things, moving around, not always thinking through how this was going to apply to their larger care management paradigm, but eager to get started while there was a subsidy for their participation. And there have been some good things that have come out of it, and there also have been some who've flamed out. The counterexample to that in Monopoly is the person who doesn't want to spend anything, and they're content to sort of try to amass their fortune by just passing go over and over and over again, taking their $200 and being very conservative, maybe saving up for an expensive property or something like that. And we see a lot of that now. There's hesitation on the parts of some people in the marketplace where they do not want to commit to this idea of population health management as a topic unto itself, and are more content to say it's an augmentation or something incremental to what they have been doing already. And that kind of thinking leads them to not really invest in infrastructure, not really invest in changing processes, doing things that are close to what they've done heretofore. Well, I think that the sweet spot for population health management is somewhere in the middle. I think that it's definitely different enough that it should be planned for as a separate activity. It's not just an augmentation of the way that hospitals and practices do treatment. It's not just running some additional reports and looking at what they tell you and then having someone think about how to operate better. It really is a commitment toward a specific paradigm that could be transformative to your entire care model. However, it should be entered into thoughtfully, and not just because there is money available, but really with consideration of the long-term approach toward treating your entire patient population, because you can quickly go down this path of trying to do all of the buzzword activities and find yourself short on cash when it comes time to actually do something meaningful. The good news is that this isn't really wishful thinking. The fundamental tenets that have started to emerge in population health management around care coordination and management have really been leading to actual positive outcomes. People are seeing, as they put more energy into managing the transition of care or the execution of care, patient outreach and other activities like that, these things have really started to make a difference. And so there are a number of reports that have been coming out from various corners showing that these kind of activities will bear fruit if people commit to actually executing them. And so with that in mind, that there's a rational reason to try to approach this population health management as something unto itself, but knowing that people aren't starting from ground zero, in as much as most hospitals start with some sort of case management program, I want to talk a little bit more specifically about the differences between the two. So population health management versus hospital case management, what really is the difference? And so I think I'll try to illustrate some of these differences by looking at each of these letters in turn. So if we look at the population versus the hospital, the scope in which one is going to be responsible, it's going beyond the threshold. As I was stating earlier, many case management programs really rely upon people coming across the threshold being assigned in a caseload for a case manager, and that case manager then may follow them and be an advocate for them, arrange their insurance obligations and understanding eligibility, being their advocate to make sure that their care within the hospital itself is actually top rate and that they're getting what they need, but also being having a fiduciary relationship with the hospital to make sure that the care that's being provided is, to the extent possible, profitable care and appropriate care, and is something that the hospitals can be reimbursed for appropriately. That is a necessary and important function. When we start to talk about population health, we have to think, though, that it's not really a patient-by-patient proposition. It's really a population and total proposition. So a population is different than a census or a panel or a group of patients. If you just have individual patients who are showing up and managing those patients one at a time, that's sort of a passive approach, and it forgoes some of the important parts of population health management, namely being able to have some context and understanding of the population that the patient belongs to in order to pre-design a course of action that will lead to better outcomes, not just for that patient, but for all patients like them. And so this idea of population health management tries to aggregate patients of a particular kind, whatever that kind is a population of interest, and do a number of things. Populations can surface individual patient risks by doing a number of statistical techniques and or other kinds of things. You can group patients and then think about who they are specifically and what they are at risk of. This helps you to vector your time and to allocate resources in an appropriate manner. Another dimension of this is populations can have pre-encounter planning. And so we don't have to wait until we see a patient in order to think about them and understand how they're going to impact us in the future and do something about it now. So there's a number of different kinds of things that organizations can put in place to reach the different sectors of their population. They may vary in intensity, and they can decide how much is worthwhile to do, but just having the population present, and when I say present, I mean more than just a generic definition, like I'm looking at my diabetes population, but actually going and finding out what patients belong to that population really has advantages as opposed to waiting for them to show up. And I'll talk a little bit more about that a little later. Populations can have proactive outreach and preventive care. And so a number of value-based care initiatives sort of start out trying to deal with the high utilizers or super utilizers, or sometimes the high cost patients, or they have a goal of preventing readmissions. That's great, but I think that where the real gains will come in is when we can move past the ones that are forcing us to react and move toward the ones that we can keep from getting us into that position in the first place. And so there are a number of more sophisticated organizations that are starting to move down and have different tiers of intervention, and that is something that's positive about population health management because it enables that kind of thinking. And then the populations can be stratified and delegated across a team. So it's not incumbent upon one case manager or care manager to be the sole responsible party for managing entire population, but this can be a distributed function with varying levels of authority and power, and the team itself can own the population and individual patients delegated out, and thereby spreading the resource pool around so that more can be done. So that's one difference. The second difference, when we look at health versus case, we're talking about the extent to which population health management and case management are looking. So we want to look in population health management beyond the episode of care that we're currently in. And so the case manager has often a number of different cases, and their caseload is not, I mean, there has to be some limits to what they can do. And once patients leave the hospital and enter into post-acute care, often their reach and their ability to impact that patient falls off and attenuates in a noticeable way. Not that there aren't efforts to overcome that, but without partners on the outside, so to speak, those kinds of efforts sometimes get stymied. So how is it that we can effectively look beyond just the episode? And this is really what population health management is trying to do. Basically saying we are concerned certainly with the here and now. What is going on with the patient that we have an encounter with, if we have an encounter with them, and we want to manage them to an appropriate place for that episode. But we also want to anticipate the impact of future episodes, given that this patient is a part of our population. And so we look out and try to understand where that patient is going to be across the entire continuum and all of the tenure in this population of interest. And furthermore, beyond just trying to understand the here and now and the hereafter for that particular patient, there are implications and things that can be learned from that patient's experience that impact the measurement of the population. And so getting information and being able to feed that information into the ongoing analysis about the population benefits not just that patient and their episode, but benefits the entire population that we're caring for. And so it's a slight shift in mindset where we're not primarily focused on trying to optimize care just for the patient and what's going on with them now, nor are we only focused on trying to optimize the care experience from the perspective of that hospital, but we're trying to optimize it for the community that's caring as well as the entire population. And that may make different kinds of choices come into play over time as that expands. And then finally, both of these, population health management and hospital care management, are forms of management, but there's a distinction in the level of comprehensiveness that is often held. And once again, I recognize that in some of your organizations, the term case management may in fact incorporate all the things I'm describing as population health management, but I'm trying to make a distinction that is present in some places just for the sake of this discussion. So it's really the idea of moving beyond autonomy. Right now, hospitals have a lot of power to be autonomous, and hospital systems even more so. And so they don't have to collaborate as much as some of the population health management models would suggest. But the mindset as we move from an HCM to a PHM world is, I'm not autonomous, I'm really part of a broader fabric that is entrusted with the welfare of this patient. And so the management activities that I do has to be not just for myself, but also for that entire fabric. And so case management does have an advantage in that it does have visibility in the inpatient setting as to what is going on with a patient, and that's often a blind spot for all the different kinds of providers that are outside of the acute care setting. That activity, I think, is still squarely in this case management function, and I would argue that some of those fiduciary responsibilities that case managers have to a particular facility are important and need to persist even in the population health management world. So this is not to say that PHM replaces case management, but I think that it's an augmentation of that thinking. But a lot of that is really centered upon the activity that the hospital is involved in most directly. As you move beyond just the case management activities inside of the hospital and look at hospital systems, there are a number of different players that are still under the same roof as the hospital. It may be other hospitals, it may be employee physician, owned physician practices, etc. But the coordination responsibility is a little greater because there are multiple partners, and there are likely some partners that are not affiliated directly with the hospital system. They may be referral relationships, they may be ancillary services, service providers, social work organizations and the like, but they are controlled and trusted and well known often and have a workable relationship with the acute care facility. So as we move from case management to what I'm calling care management, moving from just the facility out into the system, there are a few things that are a shift in mindset. Now there's shared accountability beyond just the case manager's accountability for moving forward on their caseload. There could be other kinds of paradigms. For example, within a system, there may be patient-centered medical homes where now the primary care physician has certain responsibilities, even in relationship to what happens to a patient inside of the hospital. So having more partners and players at the table brings a shared accountability and starts to spread that responsibility in a way that benefits the patient, because now the patient's group of people who are looking out for them is larger. They're likely, in this case, in systems, shared systems. That's not always true, especially systems that have grown by acquisition, and there are multiple systems there. But in terms of technology, platforms, electronic health records, and the like, there's likely some in most of the the bigger or well-organized big systems, some ability to share information. I know it's not in an ideal state, as I hear from many people who are in those systems, but there's at least that possibility. There's also the ability, because of the authority of being under the same umbrella, is a strong change management. So if the programs need to change, or we need people to, or we need entities to behave a certain way within the process, there's an ability to, through formal authority, to actually facilitate that. And we can start to take into account whole person considerations, incorporating behavioral health and long-term care and psychosocial factors, etc. But then when we look further, population health really starts to move into the community itself. And so the relationship goes beyond just the entities, often goes beyond just the entities that are under one roof, but starts to engage others who are not affiliated, and engage them in broader numbers presumably because the populations that are being managed now engage a number of different kinds of entities. So that said, the care management activities and care coordination activities can happen at all of these different levels. But when we start to look at the definition that Chilmark was putting forward and others, this idea of having a broad network with multiple stakeholders that are potentially independent with one another really starts to get at population health management. And so the community partners will likely have a specific and value-based care arrangement, specific financial relationship with whoever the convener is. They may be the convener and the hospital is participating in, but this network is defined and well understood, and that's an important factor because ultimately there's going to be some iteration on the process that is used for population health management. And when that iteration happens, the question is, how does one bring about change and impact organizations that are not under my administrative control? And the answer is by creating a common governance that all the organizations subscribe to and enables that continual improvement to happen in a prescribed way, which is going to be important for any of the programs to move forward. One point here about leakage. I think that historically there have been hesitations with participating in these broader kinds of initiatives because people didn't want to, organizations didn't want to lose their patients to competing organizations. And I think that this concept is still a valid one, but I think that population health management gives you an opportunity to set up centers of excellence that enable you to not only demonstrate in a tangible way to a patient population your competence and best interest for them in as much as you're facilitating them through this specialized process, but it also enables you to have more touches and interactions with them in a very deliberate way, because underlying the entire philosophy is this idea of trying to have a greater patient engagement and a greater relationship with the patient. So I think that leakage is certainly always there. In our experience, focusing too much on that can be a distraction. You should just count that as being a part of the landscape and sort of moving forward. But when it comes to defining your measures and your metrics and your governance and your ability for change management, it should be within a defined network and not some amorphous network that has other kinds of partners who are not beholden to that governance. So moving from care management to population health management, there tends to be shared control with formal financial relationships. And so there may be an anchor tenant and a governing leader, but often that leader has to negotiate for all of the participants to continue to follow. And so the control of how the program rolls out is really ends up being a shared one in our experience, even though there may be an anchor tenant. There are heterogeneous technologies. You can no longer rely upon everyone having the same electronic health record or being a part of the same HIE arrangement or having the same kinds of data that they capture, particularly as you move across domains and start to get into certain specialties and or other kinds of participants like social work, et cetera. And then there's a challenge on normalizing the workflow. Obviously, the more parties involved and to the extent that this is sort of their everyday concern versus a sideline concern, it may be more challenging to try to herd all the cats, so to speak. And that challenge should be understood going in so that you can meet it head on and not let it derail a program. And then there are always out-of-network entities. In fact, there are some who say when it comes to some of these value-based care initiatives, there really is no network because patients have the freedom to go and see whomever they want. And so trying to hold them in this network and hold ourselves accountable for it is a little of an exercise in futility because the patients aren't bound to do it. Well, I think that the idea that's being espoused is how is it that you can be compelling to the patient population so that they want to stay with you and your organized network that's taking care of them versus trying to figure it out on their own. Now, there are very practical and real considerations that patients have: proximity to care, trust, and other kinds of things. But I think that these evolving and relationships will certainly start to pay off. So I want to, now having gone through those three letters for each one of those acronyms, and now you have a better sense and idea of what I'm talking about when I talk about case management and population health management and care management. I want to stop and do the next poll, which is using these categorizations that I've been speaking about, what level of management, meaning case or care or population health, is your organization most heavily involved in? And so I'm going to launch that poll now. If you would respond, and then I'll share the results with you. The votes are still coming in, starting to slow down a little now. All right, looks like things are slowing down. I'll stop in 5, 4, 3, 2, 1. And so I'll share these results with you. As you can see, it looks like many of you fall into 40%, according to this poll, into the care management as I've defined it here. And I've suspected that would be the case because most hospitals are sort of a, just a beehive of activity, and it's almost impossible to be totally isolated without the use of some partners and some other external parts of the organization beyond the hospital. But it looks as though there's a healthy split, 27% versus 30%, that are doing either what I described as case management, really focusing mostly on the acute care facility itself, or population health management, going out and having a broader network beyond just the employed organizations and small curated set of partners. So this is a pretty diverse group. There are some who said none of the above, but it looks like there's an entire spectrum out there, and I think that that's an opportunity for all of us to learn from one another about what works and what doesn't. So thank you for participating in that poll. So another piece of good news is population health management and value-based care can work financially. And this is a little bit of a tricky thing because everyone's trying to figure out what's the magic set of numbers. How do I negotiate with my payers about a particular arrangement, and what kind of incentives and what kind of gain shares and what kind of risk should I take, and how do I figure that out? And I think that the punchline of what I'm going to talk about here is doing population health management on your own accord and starting it now and getting your organization in the mindset of managing populations will help you to understand those populations and do the necessary math, if you will, in order to figure out what is really profitable and possible. So I think that the counterintuitive step for a lot of organizations is that they wait until someone comes along and offers to underwrite their efforts in here. But by the time that person comes along, that entity comes along, they already have their own ideas that are more informed about what the relationship should be than the hospitals or anchor tenants. If you're if you sort of take control of your own destiny, you're better able to negotiate those things and understand what's really a good deal and what isn't, given that there are lots of different things to choose from. So prediction and proactive intervention will lessen the severity of the cases that you see in the future. If you're able to understand how to prevent someone from getting into an advanced costly state and intervene in an effective way at that time, then as you go forward, fewer and fewer of those costly cases will be managed. Ultimately, the resources that you're allocating to that can be vectored into other things, and then in that sort of virtuous reinforcement, you can ultimately address the entire population at all levels and do the appropriate level of interventions because you've been able to decrease the most intense activities enough to help you do some of these beneficial earlier activities. So figuring out how much you're really saving by early intervention and how much that allows you to move to something else is part of the trick in doing this in a profitable and successful way. If the perverse good news here is that most hospitals are not profitable when it comes to delivery of care alone. They have other mechanisms, selling food, selling parking, doing other kinds of things, but when it comes to the delivery of care, most hospitals in the United States are not profitable, and so there's a lot of room for things to be made up, and a lot of room for some important gains. And further, there's a symbiotic relationship between the hospital and the other network partners. Hospitals are very important. They are a fountain of data, and they are in many ways sort of the end of the line. If someone is coming into the ED or being admitted into the inpatient setting, or worse yet, admitted into the inpatient setting from the ED, then that information is useful to the entire care team across the continuum of care. So hospitals have an information maven role to provide to networks. They also are in many ways the biggest players seeing the most volume of patients and are in a position to help define what the patient population really is, maybe having a purview and perch that's different than any other network provider. And so hospitals are important players, and they should take that power and use it to really shape valuable PHM relationships. And the quid pro quo, or the benefit, is because hospitals are so busy, moving far beyond their own borders may be difficult, but taking advantage of an extended care team that goes across other partners allows them to now easily manage things that they actually care about, that contribute toward readmissions and other things, but do it in a way that doesn't tax their own internal resources and still has the same accountability because of those relationships, those formal relationships that we talked about with respect to the network. And so population health management and value-based care is an important combination for all hospitals to consider. So now I'm going to switch gears a little bit and not spend as much time on this next section, but I'm going to talk a little bit about the tools that are in use or characteristics of the infrastructure that you want to have to do these population health management activities. So prior to going into the discussion, I'm going to do my final poll, and the final poll is, for those doing population health management, what is your primary technology platform to support it? And so I'm going to launch that, and the choices are EHRs, HIEs, analytics package, care coordination or management tool, or something else. So if you would respond to that, we'll give a little time. Votes are still coming in. starting to slow down a little. And so I will close this poll in 5, 4, 3, 2, 1. And so as you can see, it looks like the overwhelming majority of you have some sort of care coordination or management tool. And just so you know, it's about 48% of the people on the call actually voted for that. And I think that, you know, that's probably reflective of the percentage of you that actually have these kinds of things going on. And in second place is the electronic health record. And I think that, you know, that's consistent with what we've seen, that the electronic health record vendors have been very active in trying to augment what they do in order to address this need. And so I think you're pretty representative. So thank you for participating in that final poll, and we'll go through this this final section. So to do these kinds of activities, there's certainly costs involved, and it's an investment as opposed to a short-term bill, but you have to have new workflows and commit to, in many ways, a new way of your organization operating. Some organizations form entirely different entities to manage it so that they don't get caught up in sort of the status quo set of operations and can really move forward in a way that is befitting of the population health management challenge. I encourage you to look at technology that's specifically geared towards population health management, and it should be deployed for that purpose rather than trying to just reach out to what you already have that was bought to serve a different purpose. I know that a number of the electronic health record vendors have population health management offerings, and that may be fine if you especially have a homogeneous group where, for example, Epic dominates the landscape in a particular geography and everyone has it, or eClinicalWorks or some other vendor. However, when there's heterogeneity and there are other things, you may use that as an opportunity to really look at a population health management tool as opposed to trying to retrofit something else. But the biggest thing is changing the mindset, shifting toward being proactive over reactive, being prospective about what I can do to manage care as opposed to looking back and see what have we done. Looking beyond just outcomes that often come months and months later and trying to get at real-time information that helps me to move forward smartly right now. So changing that mindset is as much of an investment as the cash that actually gets put forward for these kinds of initiatives. There are certain hallmarks that we believe you should look for as you try to build an infrastructure to support population health management. Certainly, there's no blueprint, but there are emerging definitions of what constitutes population health management sets of functionality and things that your team should want to be able to do. I advise you to design your care delivery model and make the tool fit that, as opposed to just reaching out and grabbing tools and then trying to, you know, make that the basis of your care delivery model. We've seen a number, we're in a generation now of the second and third purchase in this area, where a lot of organizations have taken on some tool and they've now had to bounce it out and replace it once or twice. And so some thoughtful thinking about your care delivery model first, it would go a long way. And making sure that those hallmarks are an evaluation of value-based program success, meaning as you go on and add more and more programs, you want to make sure that the things that you use to design the care model are the things that you're actually measuring that each of these programs are doing, as opposed to just taking the set of measures that get you paid, because you want the program, the care delivery model, to persist, not just the satisfying the requirements of a payer. So quickly, some of the hallmarks include having cross-organizational care team coordination. So being able to organize entities and people in those entities to behave as if they're part of one team, even if they are not affiliated with the same organization. That really takes some careful planning around who is in the network, what patients are actually assigned to care teams and to organizations, and how the organizations think about those patients in terms of their accountability and responsibility for them. Our view and what we've seen in the industry is that having a role of a care manager who sort of acts as the project manager for the care process, much like a case manager might do within a hospital, care manager does across the entire continuum, is a key role. So there may be certainly others, and there certainly would be others in the care team, but care managers as a unit, either working with other care managers or having a care manager per care team, seems to be an important consideration. And understand that as more of these programs get started, there are going to be network intersections where one program overlaps another, either within your organization or across partner organizations, and how is it that you want to deal with that. One point that I would like to make is that sometimes when people are in case management mode, where there's a case manager who is working as the primary responsible entity for care coordination and care management for a given patient, those organizations sometimes don't think that they have care teams. What they have are case managers. But those case managers are orchestrating things among other parties, and that really is a care team. And so even if you are in the strictest sense of case management, you can organize a care team and start to move into this population health realm, even if you're doing it as a start within your case management context. And so I wanted to state that because we hear often organizations who think that this kind of discussion is really beyond them. They're not there yet, not ready yet for a number of good reasons. But if they recast the way that they think about their partnerships internally and externally, enables them to maybe move forward and get ahead of the game. A centralized hallmark of population health management is having a unified care plan. And I know that there are different terms, plan of care, care plans, and some people mean this is patient-facing, meaning someone is giving the patient a plan for their care. Some of it is provider, some of it is shared. There are usually issues and goals and interventions that might be for the patient as well as the providers. But the idea of not just having the care plan being a documentation tool for transparency, but also an actual plan to govern future activities so that you can be prospective in the ways that we talked about and take advantage of all of those different benefits that come along with that. So making the care plan not a documentation activity, but an actual planning tool is important. And this, can happen in a number of different ways. If you have a coordinated care plan, you may design protocols from the evidence-based medicine. It may be local best practices and your care delivery model where you understand what works for you. And it may be that the care plans that are actually used are embellished or organically assembled by based on the expertise of the care teams. What's likely to happen is over time you'll have a blended approach as more and more vendor packages are bringing some of these evidence-based pieces to the table, and you have to figure out how to mix them in with what you think is right. And the way that the care plan is authored is also subject to different models. So there is one school of thought that there is a collaborative contribution to the care plan, meaning care providers of all types and the care manager are all contributing to the care plan jointly, and they all share it and all own it and all can see it, multiple authors in one. This is sort of a distributed documentation model. What's likely more likely the case in case management or organizations that are closer to case management is that it's more of a centralized documentation, command and control, where the case manager or care manager is the author of that plan and consulting and assembling inputs from other kinds of providers. There's not a right or wrong. I think that what we've seen in our experience is there's actually a blended approach where they're, both models coexisting in the same set of programs. However, I think that the flexibility to do either way and understanding that there likely is going to be some variation over time is a good approach. You need to be able to derive insights based on what you see happening, and that does not mean waiting 3 months for adjudicated claims stream to be dropped on you so you can do some sort of analysis and understand what happened across the last 6 or 9 months. But understanding, based on the data that's transactional in care today, what you need to do for the patients that are going to need you right now. There are all kinds of issues that are wrapped up that we don't have time to dive deeply into, but data always has its own set of issues, whether it's complete, where is it coming from, what's the source of truth. Understanding what measures are actually going to be useful for you. Oftentimes the measures that are put forward by the programs are not measuring your process that you're putting in place, and so you want to make sure that there are process measures that are at your availability so that you can understand how well the process is working, not just the outcomes for patients, et cetera, and populations. Lots of people are talking about predicting and optimizing the operation. I think that there's still a lot of variation on how these things are done, but certainly it's out there and important. One thing that I wanted to point out when it comes to stratification of populations, often called risk stratification, is that 2 things. One, it doesn't have to be a black art. You can look at some risk factors, things that you think are important to divide the population up, which is what most people have been doing for a long time, whether it's length of stay or some sort of acuity score that you get from somewhere, the number of visits or encounters that people have, comorbidities, diagnostic groups, your PAM assessments, whatever it might be that you know about the patient population. You can use all of those factors to help you to stratify. Similarly, there are actual models that will do predictions, and so Lace, Homer, there are other commercial models that people put forward. All of these can also help you divide the population into groups so you know where to vector your efforts. So when it comes to the actual stratification process itself, there's no one way to do it. It may be that you let these risk factors that you have data to support feed into some formal risk models, and then those help you to categorize patients. You might have multiple of those different models that you look at and view as important in different situations. Similarly, you may just look at the risk factors themselves, and based on your own understanding of your patient population, decide that stratifying just based on those factors, grouping all of the comorbid patients, or understanding according to the poor diabetes control, all of the different patients that I want to address. You can use those as a way to stratify as well without having to have a lot of fancy math. Now I'll say that math does give you a level of accuracy on certain things. However, when you're just trying to get started, you don't want that lack of a model, or you don't want to rush to use a model that you don't fully understand at the expense of doing something now. So you can use those kinds of factors. And then ultimately, you shouldn't be locked into just one way. You should be able to have a number of different ways that enable you to create composites with your own weightings on how accurate you think each of these things are. But at the end of the day, there are a number of ways that you can slice and dice your patient population in order to affect them and impact them now. But the main point is you should think about this kind of predictive functionality as you think about your population health management plans, because it's something that gives you an overall benefit and able to be proactive versus passive, as we talked about. And then you should have a technology-enabled workflow. It's just too complicated to try to do things in a manual way in this day and age. You need to be able to organize, optimize your workflow, There are lots of different systems that may be involved, lots of different kinds of data. Most people are settling in on coordination kinds of technology as well as analytic technology as sort of the heart of population health management. But at the end of the day, you need to have something that unifies your team. So having many tools is fine, but having one flow and one model of operation is more important. But you should realize that it's hard to guarantee that you will always have everyone participating on your backbone technology. There'll be some set that do use the entire platform hook, line, and sinker, and they will take it. There'll be some who use it for certain things, but they have their own systems that they'll use for other kinds of things. And then there'll be some that you need in your network who will not be able to or not be willing to use the technology platforms that you choose. It's likely that you will have all three categories as you go forward, and it just means that you have different planning burdens on how to accommodate those different kinds of users. For those obviously who use your full offering, you just need to design how the optimal use is for that tool. But when there's some who are going to be dividing, there are just additional considerations around source of truth, overlapping data capture, understanding what accommodations are made to refer across systems, etc. And if you have to have entities that are not going to use your technology at all, then there are a number of other things that you should account for in terms of do they skew our results when we do our measurements and other such considerations. So those are just a few hallmarks that you want to make sure are part of your planning for population health management, moving beyond traditional case management into care management and population health management. I think the summary is really a simple one. It's easy to get really comfortable where you are. You've had a lot of success doing the things that you've been doing, living on Illinois Avenue and making money there. But if you are really aggressive and skillful, there are higher rent neighborhoods that you can take advantage of. And I think the time is really now for population health management to become a serious consideration in your planning and your VISTA. So with that, I'll end the presentation and thank everyone for your time and attention, and then I'll turn back to Sean to see if there are any questions that have been submitted.
Thank you, Lee. I'd encourage others listening on the call, if you want to ask a question to our presenter, we have some time in the agenda today. Using the GoToWebinar toolbar on the right is a pane to ask questions. Please type in your question and we'll solicit it to Lee for some thoughts. We do have a few questions already, so Lee, what are your thoughts on staffing the acute care hospital with an on-site care coordinator in the ED?
I think that that is sort of a common practice. I was just reading some research where they were talking about a key benefit, and this could be case managers as well, was really vectoring patients to the appropriate level of care, i.e. most people coming to the ER are not coming there for ER purposes alone. And I mean appropriate ER purposes, and so if you can redirect them into places where they were better served, that seems to be a popular model. I think that obviously you have to understand your resource constraints when you're talking about dedicating someone, understanding the population and how likely they are and frequent they are to actually come in, and that would be a fruitful exercise.
Thank you. Another question is, can you say a few words about using APIs to allow central technology systems and ancillary, for example, non-HIPAA data to split and be used both in-house and by third-party groups?
Well, I guess there are two things there. APIs unto themselves, this is sort of the era of the API where people expose different web services in order to facilitate this kind of interoperability, and I think that path with, HL7 leading the way with fire as one key example is good. And so to the extent that you have vendors who support that level of interoperability, I think that's good. However, no API really negates all of the other data kinds of questions in terms of semantic interoperability. Do we really mean the same thing? Are we using the same codes? Are we using the same underlying assumptions about what the data means? How is it that we can normalize things? Are we double counting? All of that stuff is going to exist no matter what kind of APIs you're using.
Great. So another question that might be top of many people's minds are, what are your thoughts on how the election might influence population health management programs in the future?
Yeah, so I feel like I've been bombarded with a lot of articles about that. It's a way to get people to read stuff now. I would say, and this is, my views no better than anyone else's, but I would say the idea of collaborative care, and in particular, that collaborative care leading to the groups of providers to assume more risk is a bipartisan idea. I think that there has to be some way to reduce the cost of healthcare, and when you look at the legislation around that and the regulations around that kind of thing, it's always been bipartisan and supported. So I think that any emergence of new healthcare legislation is likely to still incorporate those same ideas, and then I think that ultimately we're sort of too far down the path to turn back. So I'm not very worried. As with any transition of power, there'll be people who want to wait and see, but I think that we'll overcome that, just like the stock market rebounds and et cetera.
Yeah, I think that's a great point. Another question is, how do you control stakeholders in a population health management program to ensure they follow approaches designed by the population health program leader?
Well, again, I can speak for, or not for, but I can speak as on what I've seen various of our customers do. I think that it's important to have governance, and governance where everyone has a real say. And the challenge there is getting everyone equally engaged and caring enough to participate in the process, but nonetheless, having a governance that has a defined process that enables you to everyone feel like they have ownership, I think goes a long way there. I think that, at the end of the day, the part of the reason that Chilmark and I stress this idea of having a formal financial relationship is because that formal financial relationship then has some accountability and some way to, to enforce the things that the governance puts forward. So I think that you have to put those levers in place, but it's really important that everyone feels a sense of ownership. That said, it's all a negotiation. So being nice to people is also a good idea.
Another question seems to do with analysis of effectiveness of many population health management programs. So the question that was asked was, how do you accurately measure the effectiveness of a population health management program?
Well, my view is because many of these programs are in sort of the bootstrapping phase and like a startup company, part of the measurement has to be, are you able to check the boxes that the payer, whoever is incentivizing this, is asking. So while I don't think that is the strategy you want to have in terms of a long-term plan, that certainly has to be a part of it. So by hook or crook, doing what you need to do to keep the underwriting going until such time as you're able to organize things in a way that can improve is important. But putting that aside, one thing that I think is very important is to understand not just the outcomes, but things that contribute to the outcomes. So if we're going to have a care plan and we're going to talk about doing certain protocols in order to support a bundle payment arrangement or whatever it may be, support of chronic disease management, I want to know how, if I do these 5 things, which of the 5 really had an impact and which of them really didn't? Can I streamline that? And by just looking at outcomes, I don't get enough granularity into and insight into the impact, the relationship of what I did to that outcome. And so having models that start to take into account the activities that you're doing within a care plan protocol, I think is going to really be the true way to evaluate these programs, because at the end of the day, you don't want 5 different clinical delivery models. You want one, or one with some variations, but the only way to do that is to evaluate your process as well as the outcomes.
And I think one more question that came from the audience is, as their organization begins to undertake moving from a case management philosophy to a population health management paradigm, they're running into patient consent problems when sharing data. Have you run into this before, and how are you able to overcome it?
Yes, we always run into it. Obviously, depending on where you are and how stringent any state regulations are on top of what HIPAA requires, factors in. But I think while I've always seen lots of hand-wringing about consent, I've also always seen it overcome. And so I think people who are trying to do the right thing, who talk about it long enough, they find ways to get around it. And there are lots of different models now that you can look at to see how people did it and when they apply, whether they are having blanket consents for certain kinds of things, for treating the organization, the Federation of Providers as an entity, boy, the term just slipped out of my mind. It'll come back to me, the HIPAA term, but I'm no lawyer, so I don't want to try to give any legal advice about what is going to work, but what I can say is I've never, while I've seen it always come up, I've never seen that be a roadblock to progress when people were determined.
One more question is, how do you overcome the struggles of aligning disparate entities within a community around a single IT solution, or just coming together to select an IT solution amongst disparate perspectives and organizational agendas when they have their own competing governance structures?
Well, I think it's important to, when you're talking about the population health management backbone, if you will, you should choose something that is not trying to rip out everything else. And so embracing the heterogeneity of the network, understanding that you're going to have those multiple categories that I was speaking about, where some are going to use their own system no matter what, some are never going to touch it. Taking that and having a solution that doesn't depend upon everyone having total alignment. And if you do that, then the system becomes less threatening to all the incumbent systems, and you can have a conversation to say, look, even though you're going to do something with your EHR and someone else is going to do something with their hospital information system and whatever the case may be, if we're going to be one team, there has to be something common about what we do, or else we're always going to go through endless translations that are not going to be fruitful. Each partner is going to change technology on their own pace, which will be disruptive to the whole team. So we should agree that there has to be something that we hold in common. And that common thing won't replace what you have, it'll co-opt it and augment it, and we'll be able to grow from there.
So maybe one last question. As you talked about shifting from case management to population health management, you mentioned several steps along the way. For organizations that are thinking about making this transition or already in flight, what are the primary and secondary technology investments they should investigate, and why?
Well, you certainly should take stock of what you have and what you are trying to do. We gave a talk, I guess it was a month or two ago, about where to start with some of these value-based programs, whether it's better to start with analytics versus care coordination. And I think our answer was both. However, if you really had to force rank between them, doing care coordination is actually accomplishing your goal. Doing analytics is just trying to give you some insight into how to accomplish the goal. And so I would try to go towards something that was emphasizing care coordination, care management, the integration of care teams, interoperability, being able to fold in the results of analytics, preferably having some onboard analytics. But I think that is sort of my advice, is to get something that lets you do as opposed to lets you just analyze, and lets you do instead of just layering on what you've been doing that isn't this, i.e. working with an electronic health record, for example. So that's sort of my top line advice.
Well, thank you, Lee. We appreciate the session today and your insight and taking the time to answer all these questions from our audience. We hope that the folks on the line have enjoyed the session and found it valuable. As we had mentioned, this is part of an ongoing series offered by GSI Health, where we will continue to provide our thought leadership in the industry on changes related to population health management. Please keep an eye on our website, www.gsihealth.com, under the events section for additional upcoming activities that you will be invited to. And we look forward to engaging many of you in the future.
Thank you very much. This concludes our webinar for today.